Welcome back, everyone. I hope you had a good break. And now we're going to continue with our conference and focusing on, well, new medications. That's what Dr. Elizabeth Dale is going to speak about, and here she is to start this second part of our conference.
Good morning. Thank you, George, and thank you to the Glaucoma Service Foundation and Dr. Lee and all those that helped to put this wonderful conference together. So again, I'm Elizabeth Dale. I practice at Wills Eye and around the Philly area in New Jersey. Today I'll be talking about new medications on the block. So many of you may already know this, but eye drops are really the mainstay of glaucoma treatment. And when we're diagnosed with glaucoma, for many patients, this is often the first form of treatment that we undergo for glaucoma. And most people with glaucoma will be on medications or eye drops at some point in time. And other forms of treatment, as you've heard already today, include lasers and surgeries. So before we get into any new medications, we'll talk about how glaucoma medications work. So we can think about the eye with this sink analogy that you may or may not have heard before. So we can think of the faucet as filling this basin with water, and then there's a drain in which the water leaves the basin. As a comparison to our eye, the ciliary body produces aqueous humor, or the fluid in the front of the eye. It circulates into the anterior chamber and then drains through the trabecular meshwork, so through this drain. And the way that medications work is a variety of mechanisms. If the pressure is too high in the eye, we eventually get optic nerve cupping and glaucoma damage, like Dr. Lee discussed with you. You can see that here with this glaucoma optic nerve head cupping progression. So when we use our medications, we aim to either turn down the faucet and reduce the amount of fluid that is produced in the eye, or to improve outflow through this clogged drain. So there are many advantages to eye drops. This is a non-invasive way to help control the eye pressure and to slow or stop the progression of glaucoma. But we have to use eye drops to get the benefit from them, and there are many reasons that we don't use them. But if the eye drop doesn't go in the eye, it's not going to give us its benefit. So as we can see here with the gallery of eye drop faces, there are a variety of reasons that people might not be happy with using their eye drops. And for those of you that either have glaucoma or have a family member with glaucoma, I'm sure you can delineate any number of reasons to not be adherent to your eye drop regimen. Cost is an issue for many patients. Inconvenient dosing can be a problem if the drop has to be used many times in a day. It can be difficult to administer drops. I have a patient with severe rheumatoid arthritis who can't squeeze a bottle to get the drop into her eye. We have to remember, and in our aging glaucoma population, it can be easy to forget to use some medications, or patients that have dementia may not be able to remember it all. We can have adverse reactions. We can have symptoms when we put them in, like burning upon installation. And if we have dry eye, the glaucoma medications can actually worsen our dry eye and make our eyes feel rather uncomfortable. Really, at the end of the day, all of these factors play a role in our quality of life. So if we are increasing the number of medications and trying to control the pressure, these problems tend to propagate and become more significant. So as the number of medications increases, it becomes even more difficult, and it has greater effect on our quality of life. So the last time we had a new glaucoma medication on the block was in 1996 when a prostaglandin medication was introduced. These include some drops that you may have heard of: latanoprostene, Lumigan, Travatan. But since that time, we really feel that we need more effective therapy that doesn't have many side effects, has an easy dosing regimen that we can remember and tolerate. And ideally, if we're able to get a better effect with fewer medications, then we can control our eye pressure and maintain stability and prevent progression of glaucoma. So our current medications tend to focus on the faucet, or the production of aqueous humor, and our sort of non-conventional outflow pathway, or the non-conventional drain. But 80% of the fluid outflow in our eye goes through the drain or the trabecular meshwork. And so we really need more medications focusing on the trabecular meshwork. There are 2 new medications that focus on this drain. These include ROCK inhibitors and nitric oxide donating moieties, so we'll talk about those next. So ROCK inhibitors work to incite this enzyme cascade that relaxes the drain. So it increases its permeability to enable more fluid outflow and therefore reduce the eye pressure. So the most recently approved medication in this group is one that we have in our offices and in the pharmacies now called rhopressa or netarsudil. They tout this triple action that they've seen in studies in which we have that inhibition that I've just mentioned to improve our fluid outflow. We also have some effect on fluid production to turn down the faucet. And there's a thought that there may be some benefit on the venous pressure around the eyes that can play a role in eye pressure as well. In studies, it was dosed once daily and compared to timolol for its approval. When the pressures were down at levels below 26 or 27, its effect was comparable to latanoprostene and to timolol, some of our other standard glaucoma medications. At higher pressures, it was found to be less effective. The more promising results were seen in study in which the combination of that netarsudil plus the latanoprost prostaglandin were combined. This is not yet approved, but I think we saw better effect of this combination medication. And it's thought that the 2 working together sort of boost each other's ability to lower the pressure. Generally, this is a safe medication. In studies, there were no significant adverse effects, no systemic effects, no effect on blood pressure or heart rate, and really no serious adverse events. But there was one common side effect, and that was this transient redness that actually we see with many of our other medications, including those prostaglandins. It was found that it gets better over time, and it tends to be mild. So because this medication is dosed in the evening time, it's thought that over the course of 3 or 4 hours while we're sleeping, the redness gets better, and then we notice it a bit less. The next group of medications is this group called the nitric oxide donating moieties. So they work in a similar fashion to relax the trabecular meshwork, unclog the drain, improve our fluid outflow, and again, reduce the eye pressure. They do this by coupling the prostaglandin medication to use that non-conventional outflow that I mentioned with this nitric oxide donating compound that can improve the outflow through the drain. So again, in studies, this was also dosed once daily and it was compared to timolol. It was thought to be comparable to timolol and to latanoprost, maybe lowered the pressure about 1 point more in studies. It was also fairly well tolerated with similar effects to other prostaglandin medications, that backbone compound. And again, the most common side effect was this transient redness. Some people complained of eye irritation or pain after instilling, but it was found that those symptoms resolved within a short period of time after putting the drop in. So in conclusion, we really need effective and well-tolerated medications in glaucoma. We have these 2 new medications. The question is, are they revolutionary? Is this a magic bullet? Will this be the answer for us in glaucoma care? Well, it solves a couple of issues. They both have favorable dosing regimens with once daily dosing, minimal side effects aside from that transient redness. They target the main outflow drain, which is a new focus. And they may, in my feeling, I'm not sure that they're going to be the magic bullet, but I think that they can be good adjuncts for those that need slightly lower pressure. So this may be a good addition to a pre-existing treatment regimen or a change for someone who needs just slightly lower pressure than they have at present. Thank you.